myself is I'm Jamie McKinney. I am a social worker. I'm a licensed clinical social worker. Yay. Um, and I currently work at the VA, and I've had a medical focus, medical and mental health. So physical and mental health focus. And I've been a social worker for 11 years now. Time flies when you're having fun. And I went to Baylor University, and I actually got my bachelor's and my master's both from there. And I had the opportunity of doing mental health treatment during my internship. And my initial job, when you graduate, you're like, I just hope I get a job. So my initial job was with a school, with a program called Communities in Schools, and I was there for a year. And then after getting that experience with middle schoolers, I was able to get a job with one of the local hospitals in Waco. And then that I've been in either medical or psychiatric hospitals since then. So in the change and what has happened, previously you could be a LBSW, a licensed bachelor social worker, to work in a hospital. But at least I know in Texas, to be a hospital social worker, about 90% of the time you have to have your master's degree. They do want a licensed master social worker. And I think the change occurred, at least what I was informed, is because they do want us to be able to practice independently and assess for mental health symptoms. So we have, of course, psychosocial pieces and resource coordination that we do, but they also want us to have that mental health capability to be able to fully assess and independently and make determinations when needed. So you would have to, if you got to the point, I'll talk about like requirements first, and then I'll go back a little bit into how I got started into it in my experience. So if you are wanting to be in a hospital as a hospital social worker, or even in a clinic setting as a clinic social worker, like doing outpatient social work at, like a primary care clinic, or maybe a community health clinic or free health clinic, then normally 9 times out of 10, you will have to have your master's for the reasons that I previously stated. And also, if you are going to be at any psychiatric facility, you still have to be an independent practitioner. Independent practitioner piece is huge. And in the state of Texas, the LMSW can practice independently, not on the same level as a LC, but we can do that mental health piece. So you can, as long as you do have that master's degree, then you can also get hired on to do work at a psychiatric facility. And depending on the psychiatric facility that you're at, you might have different responsibilities and different looking from hospital social work to psychiatric social work. This will kind of give you a little bit more of my background. So when I started out as a medical social worker, I was working on a floor. We did not do emergency department social work. I was in a smaller hospital, and there was 3 of us who covered the entire hospital. So I was working, I have experience in working with the cardiac unit, renal, so folks with kidney disease, end stage or other, and then also in the ICU, and then mother baby or postpartum. And even though, we're talking about physical health throughout this, the mental health component is what I would get called upon often. It would be like, someone just got a diagnosis of cancer. Can you come and just, do some brief counseling with them? Can you come in and just kind of assess the situation because we think that this person is being abused? And that always has its own mental health component. I talk often with the interns or students that I take about being able to fully and competently be able to complete, mental status exams, check folks' orientation, always assessing for risk, no matter where you are. If you know how to do a good suicide risk assessment in a way that is makes the other person comfortable because it's a difficult topic, that is a skill that, I mean, you will go far in social work if you can do that. So you have to be able to be flexible, but you have to have knowledge about how to do those mental health assessments also while getting psychosocial history, the current stressors, how things will affect their medical treatment and how it will affect them when they go home also. And then also, I had an opportunity in working at a level 1 trauma center in the emergency department. So at a larger, much larger facility in Central Texas. And emergency department social work was very fun. It was something, I mean, all of it is something different every day, but this was something different, you know, at like 11 p.m. and there's no one else there, or 2 a.m. and you're like, I don't know what I'm doing. So you're just trying to, you know, figure your way out, and you get to lean on yourself and really get to trust yourself. So, and a lot of that work ended up being, we have someone who potentially needs to go to a psychiatric facility, call the social worker, have them come in and assess. So that became a huge duty for myself and my colleagues at that time. And this is why I say, you know, being able to have those strong assessment skills is so important, because at that point in time, you know, you are assessing for, you know, seeing if you see any psychiatric symptoms actively at that time. You're assessing, of course, for risk of the person being a risk to themselves or others. You're gathering that collateral information, talking with police, talking with the physicians, working as an interdisciplinary team to get things done and get people moved to the next setting, which is normally an inpatient blocked psychiatric unit. So my first 6 years just about was that, doing, well, about 5.5 years was doing those things, getting people moved over. And then I was blessed and I had the opportunity to move over to the VA, and I got hired on with their acute psychiatric unit as one of the 4 social workers there. And what is this is something just to kind of encourage folks, if you're ever feeling like, you know, I just don't know if I can get hired on at a place, or I don't know if I'll make it. I for sure applied to the VA, I think it was over 16 times in various different places, and either got no's or got like, oh, you're being referred, blah, blah, blah. And I was like, no, this is where I really want to be. I'm just going to keep doing it. I could have stopped applying. I could have got frustrated, but finally I got on. And I think what happened is, I honestly feel like God put me where I was supposed to be after I got the experience that I was supposed to need. Because then once I stepped in with a confidence that I don't think that I would have had earlier in my career. And I maybe would have either got burnt out or overwhelmed. So on the psychiatric facility, and I've worked in 3 different ones. At that level 1 trauma center, I had helped cover it, the one that was there. And at that point in time, we did a lot of, you know, psychosocial assessments. But the real meat and potatoes of my psych experience came at the VA. And there you get to see literally a taste of everything. And when I say a taste of everything, I mean, when you open up your DSM-5 and you're kind of thumbing through, and you're sitting in class and you're saying, oh, okay, well, I know how to diagnose for bipolar, or I know what schizophrenia or schizophreniform looks like. And in my head, I see that, and, you know, I can tell you that criteria and the length of time and things like that. Well, this is where you really get to see it actively in action. And I had seen some of that, but not, you know, to the extent. So we for sure, when I say we, myself and my team, got a taste of everything. My goal there was doing case management, of course, brief therapeutic interventions, lots of assessing for risk at people's discharge. Again, you will hear me say that over and over again. If you can assessment, being able to assess is like our, you know, it's our guiding light. It's our strongest muscle as social workers. So just being able to kind of hear and then formulate the plan and work with our clients in a way that we know that we're at least assisting and helping with them. But that has been the biggest part of my career with the VA. I've been with acute psych. I was with acute psych for 4.5 years, and now I am in suicide prevention. But with suicide prevention, I do more administrative work now, so that's a new muscle that I'm building, but I also still get to work on the acute psych unit with veterans who we have identified as being high risk for suicidality, suicide behavior, suicide risk. So there's a caseload that I follow outpatient, which that is a whole different, I mean, we could talk about outpatient in its own for, hours, and that's another muscle that you build. So I think that, when you work in a hospital setting, you always have your team and you get to work together. And that is amazing because you have an IDT, you have people to bounce ideas off of, you have people to speak with. Sometimes you are the only social worker. So you do get that experience where you're like, this is my voice in the social work perspective. But sometimes you're not, and you do have people to kind of bounce these ideas off of, talk about ethical practice, look at things in the broad scope that is social work. But then with outpatient, sometimes it's like, well, they're not contained within four walls. And so we go back to those assessment skills and being able to trust yourself. So that's why I'm so big on building that up. So I initially wanted to be a physician. I knew I was going to be a doctor. I could have told you that, I was Dr. Barbie for Halloween several times when I was little. But I got to school and I was taking all the classes. My grades were fine. They weren't like amazing. They were not horrible. They were fine. But when it got to the point where you shadow and you follow a physician, I was like, this is not what I want to do. I would like to be able to be at home, but I still want to help people. I want to be able to give part of myself, but I don't want to in this way. So when I had that shift in school, I didn't know what I wanted to do. And I happened to be talking about, the fact that I was, when you're in school, everything's, oh my gosh, what am I going to do? Life is over. I was talking about how I didn't know what I wanted to do or what classes I was going to take the next semester because I knew I didn't want to continue to be pre-med. And one of the VA social workers who was working as an adjunct in Waco, amazing woman, she just retired last year, or a year and a half ago. She tapped me on the shoulder and she said, I'm sorry, I'm not trying to be nosy, but maybe you should take this intro to social work class. And I kind of looked at her and I was like, well, I mean, I guess I'll try, because she was explaining, social workers are jack of all trades and they help in so many different ways. And I was like, well, okay, so I'll try. So then I took the intro to social work class, and after they kind of broke down how broad the degree would take you and how many different job opportunities there are and how many different areas within just all of business, nonprofit, hospital, all of this that we kind of have our hands in, I was like, oh, this is what I want to do, because I could do so many different things. So that is how I ended up becoming a social worker and going to the social work degree. So I told them sometimes being nosy is a good thing, and listening and talking to folks all the time. I would just really quickly, in general, the degree is versatile in being a social worker. There's some of us in my class that graduated who we ended up working for hospitals or schools. There's some of us who literally became like behavioral analysts for like Dr. Pepper and Jack in the Box, like I'm talking about corporate entities. So it's a versatile degree. But what brought me to being a medical social worker, and I think some of the benefits of medical social work is really there. It's just broad. There's so many different opportunities within medical and psychiatric social work. It doesn't look like just one thing. It's not, oh, well, if you go into being a psychiatric or a mental health social worker, the only thing you would do is sit down across from someone, from 7 different people within your 8-hour workday. That's not always what it looks like. Now, if you want it to, it hands down could. Or you could, be up and doing groups, or you could be providing case management to people who are severely mentally ill that just want to try to make it on their own, living outside. Or you can be in a hospital and you're serving those who are really at the worst of their worst to have to be in a locked facility. So the versatility and and I had already had my own personal journey and experience with knowing like some mental health, but medical with family that we were taking care of when I was younger and things like that. So I knew no matter what, I wanted to be in a medical setting because I saw where kind of pitfalls happen and the benefit of case management in general, but folks who are there to listen and be able to assess. And then I realize now how many of the social workers I had met, because my father was a social worker, that were getting him connected for, medical things, but were doing their own assessments and checking to make sure he had everything he needs, checking in on his mental health status, making sure that if he needed to be connected or do whatever at that time. And those were, of course, I was younger. I did not realize that, but of course, hindsight is 2020. So I see now, I was like, oh, that's what they were doing and asking those things for. Because I was like, that is weird. Why would you ask something like that? Like, because we're so holistic. We're not just going to focus on one thing. We need to know everything that's impacting. So. The pay is better than in other avenues. So like I told you, I'm going to put it out here like this. I am comfortable with numbers. I don't think that anybody will know, and I think it's okay. Like, we need to be able to compare and contrast, because I need to know if I'm making a low ball offer on myself and my skills or not. So my initial job, I came out of school and I was making, I think it was barely $30,000. It might have been like $29,500 or like $30,000. And so I was like, how can I live? And I have a master's degree with this. And I know that I had like waited tables for a long time. And so like in the year I would total up and I'd make like $22,000 waiting tables. And I'm like, I can't just be making $30,000. And it's not that I didn't want to do the work. It's just that I valued my degree and what I was doing. So when I moved over and I finally got to a hospital, the pay did increase significantly. It has since then. So then I moved up to, I think, about 40 something. And we even got an increase once the restructuring happened at that hospital. I left for a little bit because they were doing layoffs, things were happening. But then they asked me to come back. When I came back, my pay that was like at 40 even went up to like 51. And so there were folks who were still in their early careers that were still at the schools or different things like that. And they were going to max out at like 38, 39,000. And max out, I mean, that's as far as they would go. They knew they would stop at that point. And so I could see the growth potential. There were also other opportunities. I was offered more time, like for overtime if needed, things like that. And there was flexibility with creating programs. And so, but monetarily, the huge jump came with going to the VA. So I had heard other social workers talk about, the VA being like the holy grail for payment for social workers. And I was like, I don't get it. I don't know. I just know I want to serve veterans because, my heart was in that. My dad was a veteran. I was like, I just want to be able to serve. But then when I got hired on, and I did realize that the pay was much higher. I mean, it was much higher. I'm not gonna lie, I was flabbergasted, but in the best way possible. I think I had like, from that point on, I was at the hospitals and I was making 51. And then I had, a significant, like a $9,000 jump. And then you have growth potential within the VA for your income going up. So the first 3 years, my pay went up because I moved up a step. And then after that, I think you stay for a little bit and then it goes up. I don't know all the ins and outs. I just know that we are compensated very well. And then with that, then you get clinical license. So I got my clinical license, and there are other jobs because you come in at a GS level, and there's several folks who can, but you can come in from an intern point, not even having a year of experience as a GS9. I came in, I had more than a year of experience. I came in as a GS11. Once I got my clinical license, then I moved up to a GS12, and that was a huge jump in pay for me also. And I moved up to a 12 because I got a different job. But I think it was amazing because you also feel the value in it. And when you work with other social workers who love their jobs, but the complaint is sometimes I don't feel valued because I need to make sure I can take care of my family, I can take care of myself, I can purchase a home comfortably, things like that, and I don't have to worry. That wasn't always, the conversation prior to going to the VA. In general are for social work, and I'm trying to think from the, like from starting up, are I think one of the things we already touched about was, how do we feel valued? I think a big thing is combating burnout and compassion fatigue. A lot of jobs that anywhere we are as social workers, we're working with people, we're giving part of our energy that we have, or part of ourselves, and it can become easy depending on how mentally strenuous your job is, to end up burnt out, or even just compassion fatigue. And I think that you have to have good self-care to make sure you're taking care of yourself, that you're recharging your batteries in a healthy way, and making sure that you are putting back into your own cup to fill back up, because you cannot keep pouring from yourself to give to everyone and it's empty. You just can't. The other shoe will drop eventually, and you'll either end up very upset where you are, even though you like what you're doing, and you'll be able to tell your own signs. So everybody has their own, but I think those are some of the biggest challenges. And I think one of the other ones, if you're in a setting, where you're the only social worker, or maybe there's not a lot of social workers, is that feeling of support within that. This is the code of ethics, and this is what I stick with as a social worker. Getting comfortable with letting me explain why I have this perspective, why it's this, why ethically I feel this should happen, especially in a hospital setting, because you have so many people working with you. You have psychiatrists, psychologists, LPCs, yourself, nursing, and all of them are different disciplines. So we all are going, well, but we're bound by these codes. Yes, and everybody's perspective is different, but let me at least be willing to explain, because I think sometimes that can be intimidating, especially if you're a new social worker coming in, because at psychiatric facilities especially, you don't have to have a whole lot of experience to get on, but it can still be intimidating work. So that, I think that's another challenge also. Mm-hmm. I think I'm gonna, we'll try. Let me answer this best I can. So I'm gonna answer this to, one, the folks who are working in the settings, but then two, if you just encounter. So if you encounter a social worker, I think that sometimes it's just knowing that there are certain stereotypes that come with the word social worker. And we have to be aware that tuning in, checking in process that we do when we're jumping into any situation in social work. But we have to know that there's sometimes a negative connotation that comes along with the word social worker when we're going to see someone. So sometimes our clients that we're seeing at the hospital, or especially at a psychiatric facility, especially if somebody doesn't want to be there, well, it's like, oh, social worker, I'll get that. Well, it's like, what are you here for? So I think that it's very important that we're fully explaining what we're there to do and how we're trying to assist and those things, because I think it helps for just kind of the general population to understand that social worker is not always a negative thing. And that's not me saying it's always negative. I'm just saying sometimes social work has a negative connotation, with they're going to ask because we ask a bunch of questions. We get to know people's lives, and it's like, give me the snapshot of your life, what's going on, what the stressors are, what's the issues all right now. And, so we do that. Let me build rapport really fast, and then let me talk to you. This is comfortable. It's normal. Where we're talking to people who might not ever open up, and they're like, oh, here's that social worker again, trying to analyze my life. No, let's talk about this, and these are the reasons why I want to ask this question. And a takeaway for just a person who's working at it is, I've been saying this earlier, but to build that assessment muscle, practice with your friends, get online, read, do whatever you can. It doesn't have to look like sit down in a class all the time. And, and just get it from there. If you're in practice and you're doing that, and you're in a hospital or you're in a psychiatric facility where you have the opportunity to build that assessment muscle, then be very intentional about it. Be mindful that, you know, that is our greatest asset that we have. And so it's very important for you to build that, that assessment muscle, so then you're able to comfortably, easily, fluidly just collect information and get what you need, so then you can really kind of do good work. And I think that's one of our greatest tools as social workers.